Hello everyone, hope you're all doing great. In this video, we are going to discuss about the management of labor. Management of labor means the general instructions, how you're going to monitor the labor and what are the uterotonics you are going to prefer during labor and all. Yes, we'll go into the topic. So, management of labor. See, you have to first, you should be able to identify the difference between true labor and false labor. So, difference between false labor, true labor is very important. True labor pains and false labor So, first point is that true labor pains occur at a regular interval. Okay. So, they occur at a regular interval, whereas false labor pains occur at irregular intervals. True labor pains, the intervals are going to gradually shorten as it is proceeding, whereas in false labor pains it does not happen so. So, the intervals are going to remain longer. The same way, the frequency is also going to increase in true labor pains, whereas such thing do not happen in false labor pains, and the intensity, that is the pressure with which the contraction is happening, is also going to increase in the true labor pains, whereas it is not seen in the false labor pains. And in true labor pains, the pain usually starts at back side, that is in the back of the woman, and it will be proceeding towards the lower abdomen. Okay. Whereas in the false labor, mainly the pain is felt in the front of the abdomen. Okay. And then pain coincides with uterine contraction in true labor, whereas in false labor there is no such relationship seen, and in true labor, because of the contractions, the cervix is going to start dilating. That time you will be able to see a bloody show, whereas such things are not seen in a false labor. Clear? So, differentiating between true labor and false labor is very important to identify that the labor has started. Okay? Now, what are the initial evaluation you have to do for the mother? So, for the mother, initial evaluation should include BP, pulse rate, respiratory rate, temperature. And for the baby, that is for the fetus, you have to check the fetal heart rate, that is evaluated by using a NST or Doppler or even a Pinat stethoscope or a regular stethoscope. Okay. Then you have to do vaginal examination in the mother also to assess the cervical changes, but before doing vaginal examination, rule out, yes, placenta previa. We will see about the membranes. See, during prenatal care itself, you have to advise the mother about the chance of rupture of the membranes and the leakage of amniotic fluid. Okay. So, what is the significance of rupture of membranes? When there is premature rupture of membranes, there is increased chance that the presenting part is not fixed, and this can lead to increased chance of cord prolapse or there is compression of the curve. And if membrane rupture happens near term without contraction itself, if it is spontaneously ruptured, then labor will soon commence after rupture of membranes. And if suppose labor didn't commence soon after the rupture of the membranes, obviously there is going to be infection that can proceed as a intrauterine infection, or there can be chances of neonatal infection also. Okay. So, what you have to know is this amniotic fluid will pool in the posterior fornix once the membrane is ruptured. Okay. So, this will pool in the posterior fornix once the membrane is ruptured, or there can be sometimes a clear flowing of the fluid also. Okay. So, here you have to know one important point, that pH of vaginal secretions is between 4.5 to 5.5, whereas the pH of amniotic fluid is more than 7. And the next test we can do is nitrogen paper test. So, in the nitrogen paper, if the collected fluid is applied, when this changes to blue color, then it confirms the presence of amniotic fluid, which is alkaline in nature. Okay. At the same time, you will also be able to get some of the false positive and false negative tests in these conditions. Okay. So, false positive is seen when it is mixed with blood or semen, or there is an infection like bacterial vaginosis. And there can be a false negative result also when only a scanty amount of fluid is present. Yes? Okay. Now, another test we can do is Fern test. So, what we are going to do is, we are going to collect the fluid and smear it over a slide and allow it to dry. Okay. So, fluid collected, smeared on a glass slide, and this is allowed to dry. So, here for the amniotic fluid, you will be able to see arborization. So, arborization of the amniotic fluid is seen, and also do know what is this arborization. Arborization means just like a tree pattern, like this ferning appearance. Okay. Because it crystallizes, the amniotic fluid is going to crystallize because of the presence of substances like proteins, sodium chloride and carbohydrates. Now, what are the other methods for detection of amniotic fluid? So, other methods of detection of amniotic fluid include: number 1, detection of alpha fetoprotein. Number 2, there are commercial tests available which are going to detect various substances present in the amniotic fluid, including your fetal fibronectin, placental alpha macroglobulin 1, and then insulin like growth factor binding protein 1. Okay. But these tests are not available in India. Okay. Now, we will go for cervical assessment. So, cervical assessment We already know there are two important changes that is taking place in the cervix. Number one is cervical dilatation. Yes, dilatation you can assess even from 1 centimeter, and the maximum dilatation occurred by the cervix is 10 centimeter. At this stage, the cervix will be known as fully dilated. Okay, and it undergoes another change called effacement, which is taking up of the cervix by the lower segment of the uterus. And if the length of the cervix is half reduced, means then it will be known as 50% effaced. Okay, whereas if it is fully reduced, completely reduced, means at this stage you will be able to see the cervix as a paper thin structure. Okay. Another important factor you have to assess while doing cervical examination is the cervical position. So, cervical position in relation to the center of the fetal part. Okay. So, this position can be posterior mid cervical position or anterior cervical position. Clear? So, another important thing you have to assess is where the fetal head is. For that, we will be using the ischial spine as a prominent landmark, and from the ischial spines, we will be calculating the position of the fetal head as a particular station. Okay. So, if you see this picture, you will be able to understand. Okay. So, this is the ischial spine, which is considered as 0 station, and 1 centimeter above, 2 centimeter above and 3 centimeter above are taken as -1, -2 and -3 stations. Similar way, 1 centimeter below, 2 centimeter below, 3 centimeter below and 4 centimeter below will be taken as +1, +2, +3 and +4 stations. Clear? And at this stage, if there is a need, you can repeat your hemoglobin, hematocrit, serology, urine complete. You can check for proteinuria if there is a doubt of preeclampsia. Everything you can do. Yes? Okay. Now, we will see the first stage of labor. So, our important point here is about the management of labor. We will see the intrapartum monitoring according to the stages and the risk of pregnancies. Okay. So, if we take intrapartum monitoring, in the low risk pregnancies, it can be seen as first stage or the second stage, and you have to monitor the fetal heart rate for every 30 minutes in the first stage and every 15 minutes in the second stage if it is a low risk pregnancy. And then when it is a high risk pregnancy, in the first stage you have to monitor the fetal heart rate for every 15 minutes and every 5 minutes in the second stage. Clear? Okay. Now, other maternal monitoring, what you have to do is you have to check for the temperature, BP, pulse rate, and these should be evaluated Q4 thoroughly, and temperature should be measured every hourly. Okay. So, uterine contractions should also be monitored. Either you can go for an electronic fetal monitoring or you can go for a manual examination. While doing manual examination, you have to examine it with the palm of your hand. Remember, it is the palm of the hand, okay? And you have to keep your palm of the hand over the fundus or mostly in the fundus of the uterus, because that is where the contractions are going to start, right? So, there you have to start and you have to keep counting for the number of contractions as well as how long one contraction is going to last. Okay. For example, I am going to check for the contractions between 2 p.m. to 2:10 p.m. means I have to check how many contractions are got. Say I got 5 contractions and how many seconds each contraction lasted. So, that should also be documented. And remember that during the peak of the contraction, okay, you will not be able to indent through the myometrium or the uterine musculature, right? And also you have to do vaginal examinations in the first stage, and this thing varies, okay. It can be done every 2 to 3 hourly intervals. In case if there is a rupture of membranes, don't ever forget to examine for the cord prolapse and check for the fetal heart rate once again. Clear? Next we will see the position of the mother. See, position of the mother can assume any position during labor, okay, but most of the mothers will prefer lateral recumbency position, because lateral recumbency position is preferred. This is suggested because mother shouldn't be encouraged to lie supine, because while lying supine it will lead to aortocaval compression by the uterus, and that can lead to supine hypotension syndrome, okay. So, to prevent this, we will be suggesting lateral position, okay. And during the stage, walking can also be encouraged, okay. Yes. Next one is pain management during first stage. See, pain management depends upon the need of the mother, okay. You can offer her various options like epidural analgesia, IV or IM opioids, then sometimes even nitrous oxide, okay. Yes. And next one is we have to check about the oral intake. See, oral intake, both solids and liquids, are not recommended during active labor and delivery. What happens is, in this time, the gastric emptying is prolonged. So, the food remains in the stomach and it is also poorly absorbed. So, that will lead to either vomiting, and in some cases it can even lead to aspiration, okay. If there is uncomplicated labor and during the early stages of contraction, you can allow her with some oral intake of clear fluids in a moderate amount. And if there is a need for cesarean section or high risk patients, then further restriction after this decision making has to be done. So, when you are planning cesarean section, solids should be ideally stopped 6 to 8 hours before, and liquids should be stopped at least 2 hours before the planned time, okay. And another important management is about the IV fluids. So, you have to assess IV lines when the labor has started. 2 IV lines are good, and assess will allow not only IV fluid allowance, but also we can even give parenteral analgesia if there is pain. And in the immediate puerperium, there is a need for oxytocin infusion also to prevent the atony of the uterus, and thus it will be acting as a prophylactic measure against PPH, okay. So, for that also IVSS is needed. And also if there is a chance of dehydration or hypoglycemia, okay, or there is a need of blood transfusion, okay, very important. So, all these are possible, and hence IV assess during the early stages of labor is very important. Clear? And the next one is how your urinary bladder function is going to be there, okay. So, sometimes the distension of the bladder itself can hinder the fetal descent, okay, and it will lead to bladder hypotonia and infection. So, you have to palpate the suprapubic region if there is any bladder distension or not, and if needed, this has to be catheterized, okay, so that there will be no hindrance in passage of the fetal head, okay. Now, we are going to see about the second stage of labor. Here, the uterine contractions are going to occur more frequently, okay. They will occur in an interval less than 90 seconds also, and they can even last for longer time, like they can even last for 1 minute, okay. So, we will see the median duration of second stage now. For a nulliparous woman, the median duration is around 50 minutes, whereas for a multiparous woman, the median duration is around 20 minutes. Yes? And the next one is, you have to do vaginal examination during this stage also, and you have to estimate the fetal position, station and the cervix dilatation and effacement also. Okay? Dilatation and effacement. So, when there is full dilatation, say 10 centimeter dilatation is there, means at this stage the mother spontaneously bears down, okay. There will be pushing efforts given by the mother, okay. So, while she is doing this also, you have to monitor for the fetal heart rate, and the position during second stage of the mother, she can adopt any position she is comfortable, okay. She can even go for a squatting position or a left lateral position or a lithotomy position, anything can be preferred, okay. And what happens is, once full dilatation is happening, the perineum begins to bulge, and you will be able to see the fetal head coming like this, okay. You will be able to see the fetal head in the perineum like this, and this is known as crowning, okay. Crowning of fetal head. Clear? And the next one is about the third stage of labor. So, third stage of labor, that is expulsion of the placenta. So, here we can prefer to do expectant management, and while you are doing this, what are the signs of placental separation? So, this you should know, okay. So, signs of placental separation means we have so many points. Number 1, the uterus becomes firm and globular. Then there is gush of blood from vagina. Then there is increase in the length of the cord, especially the extravalvular portion of the cord, okay. That means the cord is descending down, yes. Then you will also be able to see the appearance of the suprapubic bulge, and you can even try to push up the uterine fundus, and while you are doing that, the cord doesn't retract up, okay. So, when the uterine fundus is pushed up, the cord does not recede, okay. And at this stage, definitely we have to do active management of third stage of labor, that is AMTSL. That includes earlier cord clamping, controlled contraction, then immediate administration of hydrotonics. Okay. So, these measures are done to prevent against BPH. Clear? Okay. Now, what are the choice of hydrotonics we can have? Hydrotonics choices include number 1, oxytocin, which is the commonly used. We can give 10 units as an IM injection after the delivery of anterior shoulder. Okay. After delivery of anterior shoulder or within 1 minute after delivery of baby. Then the second choice is you can even use misoprostol at a dose of 400 to 600 microgram orally, but the side effects are there with this drug. There is fever and diarrhea. Okay. And the another drug is symptometrin, which is a combination of syntocin, which is oxytocin, and ergometrin, and this can also be used. So, this is oxytocin plus ergometrin, and the next one is ergometrin and methergin itself, but these are associated with increasing BP since these are ergot substances. So, this is contraindicated in hypertensive women with preeclampsia, PAH, etc. Okay. And the next thing we can go is we can give carbetocin, or we can even go for tranexamic acid. Okay, tranexamic acid. See, tranexamic acid is an antifibrinolytic agent. Okay, it is a antifibrinolytic agent, and this is mostly given as IV. Mostly this is given in addition, okay, to oxytocin. Okay, and prophylactic use of tranexamic acid is not recommended. Okay, I hope you would have got some points on how to manage the drugs monitoring and how to use the hydrotonics and all. Okay. So, with this we are going to complete the discussion on management of labor. Until we meet in the next video, keep going, happy learning and take care.